Next up, a deep dive on strategies for prevention. We'll hear from experts about how pathways to addiction can be identified and addressed while providing the appropriate level of care to those suffering from pain. Please welcome on stage Robert Morrison, Executive Director and Director of Legislative Affairs with the National Association of State Alcohol and Drug Abuse Directors, Jessica Holsey-Nickel, President and CEO of the Addiction Policy Forum, Martin McCary, Professor of Surgery and Director of the Johns Hopkins Center for Opioid Research and Education, and Kristen Veasley, Co-founder and Director of the Chronic Pain Research Alliance. The Hills Healthcare reporter Rachel Rubine will be leading this conversation. Rachel, over to you.
Well, thanks so much, everyone, for being here this morning. Special thanks to our panelists as well. So we have about just 30 minutes. Want to dive right in here and a quick Q&A portion at the end. So Dr. McCary, I'm wondering from you, when you were a resident about 15 years ago, I've seen in news articles that you were told to prescribe, up to 30 to 90 painkillers for just, I guess, any surgery. Do you mind talking a little bit about if you think doctors are still doing that, and also what sort of change in your mind since then?
Yeah, looking back, it's amazing to think that as a resident at Georgetown Hospital, actually, there were attending physicians that would yell at us if we didn't prescribe 100 opioid pills for every patient at the time of discharge. And I don't know if you know much about residency, but it's trench warfare, and you just try to not get yelled at, and you just try to do what's going to have the least consequences for you. So we would prescribe liberally. We were told they were not addictive. We were told people are in pain unnecessarily, which, that is an issue. But we flooded America with opioid pills laying around. People get depressed after surgery, and they get into those pills years later sometimes. Kids get into them. Looking back, it's amazing to see that this is not a naturally occurring virus in society. This is a public health crisis that is entirely manufactured. And to answer your question about is this something that's still going on today, our research team at Johns Hopkins has graphed the average number of opioid pills that a surgeon prescribes after a routine index procedure, C-section, laparoscopic gallbladder, hernia, the most common procedures out there. And what we see in the graph is the distribution of the Wild West. Some docs are still doing 30, 60, 90. Our experts at Johns Hopkins, we just convened this week, show that for a lot of procedures, it's 10, 20, maybe 30 for some of the orthopedic procedures. So yes, it's still the Wild West. And actually, with the way we cut the data, and no one's done this before, we have the names of the high prescribers, and we're trying to engage with those doctors, doc to doc, to tell them, hey, look, this is the rest of the country, this is you. You can do better on best practices. So that's all at solvethecrisis.org.
Mm-hmm. And where are sort of medical schools in training and teaching on this?
About 4 light years behind where they need to be. On almost every subject, by the way, not just opioid prescribing, but it's an old actuarial education. And I took 4 years of Latin because I was told it was going to help me with medical school. Well, there's only one medical term that's in Latin that's been helpful. And so we spend our time on things that don't matter.
And Chris, want to turn to you. You've someone who lived with this, lived with chronic pain. So can you tell us just sort of the challenges in trying to get treatment for it, and sort of where you see the state of non-opioid alternative treatments for pain?
Sure. And I appreciate the Hill including pain in part of the discussion today, and also for focusing on prevention, because a lot of times we're waiting till the problem occurs and then trying to treat it rather than talk about prevention options. I think one thing that a lot of people don't understand is why, how has the lack of pain research or pain management contributed to the opioid crisis, and why our opioids continue to be prescribed for chronic pain. And We've had a crisis in this country for decades of chronic pain that has essentially been ignored. The federal investment in pain research is less than $5 per person. We know very little about pain mechanisms and safe, effective treatment for chronic pain. The former FDA commissioner mentioned in a New England Journal report that we're lacking evidence to assess benefit and risk and safety of virtually most pain medications and other types of treatments that are out there. So what ends up happening is that, like myself, we go to clinicians who are very well-meaning. I have a primary care provider who is amazing, but there's really no clinical data for him to assess, to say what is going to work for me, at what cost, at what risk. And so you end up kind of in this paradigm where you're rolling the dice and just experimenting with a lot of different therapies. And unfortunately, it takes many weeks to sometimes months, even years, to find a treatment or a combination of treatments that are effective to manage pain. And so what we really need are is an increased investment in pain research, that we can understand the underlying mechanisms and subgroups of people with chronic pain, and that we have an evidence base that can inform our clinicians as to, if I walk in the office versus Marty walking in the office, what is going to work for me versus him, depending on what type of pain I have and what other contributing factors I might have, like mood disorders, sleep problems, things like that. So there is, Dr. Collins had mentioned a partnership, public-private partnership with the FDA and the pharmaceutical industry to cut in half the time that it's going to take to develop new non-addictive therapies for chronic pain, and that's currently unfunded but in the works, and so that's definitely one thing that would very much help to advance both our understanding of pain and to bring new non-addictive treatments to the market.
Mm-hmm. Dr. McCary, do you want to jump in on that just from the provider perspective and trying to treat chronic pain?
So there's two, I think, separate overprescribing issues. One is the management of chronic pain. When you have physician burnout rates at 40%, and I can tell you, doctors are getting crushed out there in office-based medicine. I don't know how anyone does it, to be honest with you. I mean, my first day of med school, I saw 15 minutes per patient. I thought, gosh, people do this for a living? That's when I knew I wanted to be a surgeon. And after surgery, it's a different ballpark, because that's when people get their first exposure. And now we know that 1 in 15 patients that gets that script after surgery is a long-term user. And so that's the spigot that we need to turn off. Now, we need treatment, and I'm glad there's talk of money going towards the back end, but the root cause is that doctors have flooded the market with one opioid prescription for every adult in America each year for the last couple of years. That is the root cause of the problem. And a lot of the times, either the patients don't need it, they need far less, or they can use these non-opioid alternatives like Tramadol, NSAIDs, and other things.
And another aspect of prevention, education, just could you mind talking a little bit about what you've seen in sort of the prevention space that's worked?
We know in the prevention field that addiction begins in adolescence. About 90% of those that have a substance use disorder today began in their adolescent years, between 12 and 17 or 18. And sort of the introduction of any substance, whether that's alcohol, marijuana, prescription medications, heroin, is going to have a different impact on an adolescent brain versus an adult brain. So really, prevention is about delaying the onset of first use. And we have to do a better job of making sure we don't miss this. This is a disease, and like any other disease, it's prevention, early detection, and treatment. We want more people to survive, but fewer people to come into this space in the first place. So things that work are, there's great curriculum out there, programs like Strengthening Families and Life Skills. Communities don't have to invent education campaigns and curriculum for schools from scratch, because we have really well-documented programs and research that are great. We also have early intervention programs that when you can tackle this disease right when it begins. Right now, we know that this is a disease that begins in adolescence, but we treat it in adulthood, waiting for this illness to become more severe until we treat it, which means that there's more damage done and sort of more harm that comes from that illness. So I think the prevention components that are adolescent-based, that are on parents, caregivers, figuring out those that are at higher risk, and then also those early intervention programs. There's one program I love in New York called Project Success, which is a student assistance program. So it's like the employee assistance program, but in schools, to make sure that when you identify a 16-year-old that is developing a substance use disorder, is having risky use and behaviors, that you address that now in coordination with treatment providers. So we know a lot of science. We know about risk and protection, about how to protect kids, protect adults, and what the risks are, but we really need to focus on implementing those proven strategies and starting earlier than we are currently.
And Rob, do you want to jump in just from state alcohol and drug abuse directors, any sort of prevention techniques that you've heard from them that have been effective?
Sure thing, and thanks to the Hill for the event, and thanks for focusing on the front end work that we know is so important. Working from what Jessica talked about, and a core part of our prevention work in the states is working with community anti-drug coalitions. I like to say that the fabric of our prevention system, where we can focus on where the issue is, that's at the local level, with a cross-section of representatives from business, schools, parents, law enforcement, to really analyze the situation on the ground, look at access and availability, and also address the community norms in that particular locality, to not accept the use of alcohol and drugs by our youth as a normal activity, and to band together and to continue with pressure on that particular issue. We know particular federal programs that support this. The Substance Abuse Prevention Treatment Block Grant is an important component of our members' budget. About 65% of our budget comes from that block grant. And that's not really well known. Drug-Free Communities program employs a lot of what Jessica noted. Very important program to get at the local level and apply these scientific principles. So we know through our inquiry of our members, every single state identified the opioid issue as a top priority. That was back in 2012. So now we need to elevate, bring to scale these many important interventions.
And so off of that, I'm wondering, from you both, if you think this would be effective. President Trump said that he would like a massive advertising campaign on this. His Opioid Commission agreed and kind of offered a little bit more of a detailed look at what could work. Do you both think that that could have an impact?
So we know, just like the continuum of addressing prevention, treatment, recovery, there's a continuum within the prevention work that we know. So applying a media campaign is important, and rooting it in science and bringing it to scale, and having it be part of a comprehensive approach. States have shared with us, and at our annual meeting each year, we'll highlight states that have looked at effective media campaigns as part of a comprehensive approach. In particular, looking at the data and targeting high-risk communities has been a successful approach, working with prescription drug monitoring programs and leveraging the different agency data. So ensuring that the messaging matches up with a comprehensive approach. Think Smoking in the Truth campaign, for example, or the Above the Influence campaign. Those are two very specific approaches that have had an independent look at the effectiveness.
But the only thing I would add is that we need to, one, I think it's a great idea. We need to have more awareness, more education. The audiences are very important. It needs to be tailored, and we need to follow the science. So drug education, we know, does not work as a prevention component for adolescents. So telling a 15-year-old about the dangers of a certain substance or whatnot, adolescent brains are weird. It just doesn't work that way, right? But I think we know programs that have been incredibly effective in the awareness campaign space. We also need to make sure that we are targeting messages at parents and caregivers and others that are sort of wrapping around folks that need these types of supports. And we have to follow the science and make sure that we're sort of using the research to make sure that those messages are tailored. And we've had great success with these in the past. We even funded these for a while with the National Anti-Drug Youth Media Campaign. Had great messages that were out there. We have amazing scientists in the prevention space in this administration that could help tailor that, both at NIDA and HHS and SAMHSA, that this could be a real success and an important tool for the country.
Mm-hmm. Now, you mentioned funding. Chris, you also mentioned funding. There's been a lot of talk after the public health emergency declaration that from Democrats, from advocates, that there needs to be some more funding. So I guess, Chris, I'm wondering first from you, what kind of funding do you think there needs to be to support research?
Well, it's hard to kind of put a number on, we don't know. You could spend, $100 million, or you could find something, transformative in a $2 million grant. But obviously, the fact that we have been underfunding pain research for so many decades, that we know very little, again, about the underlying causes and mechanisms of pain. And we really need to not only develop new treatments, but then an evidence base that's going to say what works for each individual or subgroup of patients with pain, because we know that across the board, everybody isn't going to respond favorably to one particular medication or therapy. I don't know that I can put an actual number on it, but it needs to be a lot more than what it is right now. There are efforts at the NIH and again with the FDA and others to really ramp up funding, and there's a lot of programs and strategies, initiatives that have been put in place, a federal pain research strategy, a national pain strategy. But again, as you said, many of these programs are just authorizing plans, and there is no funding attached to it. As an example, something like, 100 million Americans in the United States have chronic pain. The same number suffer from cancer, diabetes, and heart disease combined. The NIH right now invests 95% less in pain research as it does on those conditions. So that gives you somewhat of an idea as to where we are and kind of what ramp up we need to really invest properly in this space.
Mm-hmm. Jessica, what are your thoughts on funding?
So I think it's our priority to make sure that the mechanisms that we've established and Congress has been committed to are maintained and plussed up. Last year, Congress passed the Comprehensive Addiction and Recovery Act. We also passed 21st Century Cures with the $500 million for treatment and recovery. This is in addition to the block grant, which is an important sort of foundation for funding that states and communities need, prevention programs. It's the constellation of these combined together, and we need to make sure we're not robbing one program to feed another. But more resources are needed, both on the research and development. The administration laid out a plan for a public-private partnership in NIH, really sort of diving into an opioid initiative with more research, new medicines, better technology. And our patients, Addiction Policy Forum, we represent 4 million families impacted by substance use disorder. We have people we love, we're in recovery, we've lost folks to this illness, and we need to make sure that we're investing in research for better treatment, as well as making sure access to treatment is available nationwide.
The 21st Century Cures bill had $1 billion over 2 years to states. Rob, do you mind talking a little bit about that? Has any of that gone towards prevention?
It has. We're taking a deeper dive in the applications. So far, we've looked at around 40, and we'll go deeper into which category. We know that all states are allocating resources to prevention. And you brought up funding. We know now we're facing about a $55 million cut in the Center for Substance Abuse Prevention, which is in the Substance Abuse Mental Health Services Administration, to a program designed to help address prescription drug use prevention. That's called Partnerships for Success Grant. So on the get-go, we're looking at challenges in this FY18 environment. We also know for the Substance Abuse Prevention Treatment Block Grant, as Jessica said, 20% of that grant goes to primary prevention. And we looked at it over the last 15 years, and through the lack of growth and not covering inflationary costs, we would need $500 million, $500 million. We need a cures investment just to keep the block grant at 06 purchasing power levels. And that's, again, 65% of what our members have for substance abuse prevention. So I agree with Jessica as well, being mindful and having the programs coordinate. But block grant for our members is critical, as is the leadership of the Center for Substance Abuse Prevention's Partnership for Success grant.
Dr. McCabe, you had an interesting day yesterday coming up with prescriber recommendations. Do you mind telling us a little bit about that and what they're sort of aimed at?
Sure. Well, my research background is really in the science of measuring quality, and in the last few years, it's been really focused on appropriateness of medical care. That is, our healthcare crisis is really a crisis of appropriateness. When you had 2 billion prescriptions written by us doctors 10 years ago go to 4 billion last year, disease did not double over the last 10 years. We have a crisis of appropriateness. So when the opioid epidemic hit, and I sort of had my own confession with how I had been overprescribing unknowingly, I got together all of our pain experts and said, let's come up with at least best practices. When you have a C-section, why is it sort of anyone's style, discretion, feel as to what you like to prescribe? Like, there should be one, best practice for, a patient that's a standardized narcotic naive patient. And so we started asking, and no one knew the answer. Like, people were like, I like to do this, I like to do that. And then they were like, well, after surgery, Dr. McCary, you're a surgeon, you might know better. And I said, well, I don't write the scripts, my resident writes them. And she says, well, the nurses follow up and maybe they would know. And I said, guys, this is pathetic. We're Johns Hopkins, we don't even know best practices. How's the rest of the country managing? So last night, we had a 2.5-hour expert panel posting the results at solvethecrisis.org for all the common procedures in medicine in a narcotic-naive patient. What should you leave the hospital with? What should that script say? It shouldn't be the Wild West. It's often 0, 5, 10 of opioids, sometimes 20 or 30 for certain orthopedic procedures. And we talk about the non-opioid alternatives that can either replace or supplement that.
And what's sort of the next step for these recommendations? Are there plans to get it in front of residents, students, doctors?
So what we've done with the National Improving Wisely project that I direct through the Robert Wood Johnson Foundation, we engage with outlier doctors one-on-one, sharing their data with them, and doc to doc try to offer help and explain and show them the best practices. Well, we're now doing that. We want to do that for the opioid problem. We've done it in so many other areas of surgical care and management. We want to do it if the funding comes through. If anyone's out there and wants to fund this, we need funding to engage with the high outlier doctors in the United States after common procedures, because we have seen a dramatic behavior change among doctors that we've engaged with on other quality metrics. So this is sort of the low-hanging fruit. We've got their names, we've got the Medicare data, we're ready to engage with the high outlier prescribing docs.
Mm-hmm. Just quick, but I think about what would it be like, and in the example that the senator gave today, and he's talking about post-surgical pain, if we had better pain management strategies that were effective and safe, so that we could even limit altogether the exposure to opioids after surgery. For example, one of the things at Hopkins that the acute pain service is doing for knee surgery is sending people home with a peripheral pain pump. So they have, analgesia from the knee down, it's controlled, and they never have to take a single opioid. So that would prevent the exposure to an opioid to begin with, and prevent the potential abuse, misuse, diversion, or overdose in a select percentage of the population.
We're going to go to Q&A in just a few minutes, so be thinking of any questions you have for our panelists. But sort of on the prescriber front, do you want anything from Congress? Should there be any mandates, or no?
Well, we'd like to engage with docs. We docs are interesting people. We only listen to our own kind sometimes because medicine's an art and we've got individualized care. We'd like to engage with docs. But to be honest with you, these recommendations that are out there now, like the CDC 7-day limit, these draconian blanket all procedure policies, they're a joke, because in 7 days, I can prescribe 65 opioid tablets. Oftentimes, you may need an ibuprofen and acetaminophen, or 5 or 10. So we've seen this massive overreach, as we often see, where states are having these sort of blanket policies, and the CDC's got these guidelines that are blind to what procedure you had done. If you have periosteum or bone screwed, it's going to hurt like heck. But if you have a lumpectomy, most people are telling us they can get by with maximum 5 opioid tablets.
And we're going to take questions here. So right over there.
Good morning, Deborah Mikas, Public Health Advisor at FDA. This question is for basically anyone on the panel who would like to address it. And that is, to what extent do you agree that the opioid epidemic originally emerged in rural communities and still tends to be concentrated in rural communities in a very selected group of states? And why do you think that is?
Any takers? Rob?
Is there something about the, I guess my question is there anything about the social ecology or the medical community in rural areas of West Virginia, New Hampshire, Maine, Pennsylvania? Because obviously, you know, people are getting surgeries and being prescribed opioids post-surgery, you know, all across the country, and yet the epidemic itself, and particularly in terms of deaths from opioid addiction, tend to be concentrated in very selected areas of the country, and maybe there's some clues there as to how we can more effectively address and prevent.
So a couple of things. I'd say, number one, I think more recently we've been seeing the epi point to some components of that. I'd also say, though, you drive up the street to Baltimore 10, 20 years ago and take a road trip to Chicago. There were heroin deaths that we weren't really chatting about at that point, and that brings in a whole nother component of studying kind of the response now versus a non-response earlier. But I think studying the epi and studying the isolation and some of the challenges accompanying rural areas and access to care, I think the number one thing we learned with epidemics is they don't change unless people understand the threat. And to Jessica's point, you have to understand the threat and you have to understand the risks associated with said issue. And I think that's what changed during the crack cocaine epidemic. And I think that's going to be, and that's why this panel is so important, educating the public in a comprehensive approach, including youth and communities where it's going to stick. And we found community coalitions and supporting them in rural areas to be effective.
You know what, sorry.
So what we know about sort of risks for a substance use, not only for a person, but it's also their community. Those are the environmental risks. And things like poverty, crime, not being able to find a job. Folks develop not just a substance use disorder because of responding to physical pain, but also emotional pain, trauma, undiagnosed and treated mental illness. This is a complex disorder with complex reasons that they develop in the first place. And we're finding a lot of communities where you have a constellation of environmental factors that are leading to a higher prevalence of substance use disorder. Again, that poverty, that crime, and making sure that we're providing specific resources to communities based on what those environmental risks are.
We have time for just one more quick question. Over there, sir.
Thank you. I'm Mike Miller. I'm a reformed orthopedist. I've been doing policy work for a long time, but I think it's great what you've done on the consensus around acute prescribing for procedures and hospitalizations, but those aren't really evidence-based best practices. So I assume you're going to be following up, looking at ways to actually determine and develop for guidelines or algorithms around what kind of patient, what kind of prescribing is useful, because not every orthopedic patient for the same procedure needs the same amount of pain relief. Because it's great to help alleviate the acute pain, because not only does it prevent addiction or dependence, but it can help prevent acute pain from becoming chronic pain, which is really where the problem starts. The third thing I want to add, my question really is about how to educate physicians and medical students and patients around the concept that this acute opioid prescribing is for dulling the pain, not completely eliminating it. I think it's a big misconception I've found around patients in the past is they think this pain pill is going to make my pain completely go away. And I try and tell them that the pain completely goes away means you stop breathing and you're dead. It's
Dr.
going to make the
McCary, do you wanna
pain
take-
marginal.
Yeah, so we're creating some patient videos for solvethecrisis.org for doctors like yourself to show their patients before surgery to get rid of this expectation that you're going to be pain-free after surgery. Look, surgery hurts and it can be sore, and we want you to be comfortable, but this idea that you're going to be in dreamland and with zero pain is part of this problem. It's that expectation. So we're educating people about the risks, side effects of opioids, encouraging them to take them when they need them, but also warning them. We've never really had that conversation. And like, to your earlier point, medicine is an art. You know that better than anybody. And so there's no blanket approach. It's not like everybody should get this one thing. But do you know that with electronic health records, the default in there is a 30-day supply? You get 70 opioid pills for routine surgery. So we're just trying to say, look, in the trenches of the residency, where they're writing scripts, 50 a day, let's use some more reasonable starting point. The evidence, the evidence-based concept sounds good, but my only issue with the evidence-based bandwagon is that it takes 100 years to get all that evidence together. Can we use wisdom-based healthcare and listen to docs like yourself?
And unfortunately, we're out of time, but thanks so much, everybody.
Thank you so much to our panelists and to Rachel. That brings us to the end of our program. On behalf of the Hill and the Pharmaceutical Care Management Association, I'd like to thank all of you who joined us today and watched the live stream. If you've missed any portion of the program, it will be on thehill.com later today. Have a great rest of your day. Thanks.